Hello, everyone. It's a great pleasure to be at the Cholangiocarcinoma Annual Conference with you. My name is Mitesh Borad from Mayo Clinic. I want to thank the conference co-chairs, Dr. Bridgewater and Dr. Merrick Bernstein, for the invitation and for the foundation for the opportunity to present today. I have been given the topic to talk about IDH1 and IDH2 mutations as therapeutic targets. So as we know, personalized medicine has become a very attractive approach which can leverage understanding of the human genome, particularly the tumor genome, to help offer the right drug to the right patient at the right time and at the right dosage, as shown here. And cholangiocarcinoma is the gastrointestinal cancer with the highest number of therapeutic targets. And I will highlight isocitrate dehydrogenase in this presentation as one of those quote unquote actionable targets. So as you can see here, IDH1 and IDH2 are two genes slash proteins that are sort of in the metabolic pathway, and I'll go into this in a little bit. As one can see here, IDH2 is in the mitochondria, IDH1 is in the cytoplasm. They're involved in the Krebs cycle, converting isocitrate to alpha ketoglutarate. When you have the mutation, you get a neomorphic metabolite called 2-hydroxyglutarate. Now, 2-hydroxyglutarate has several effects, including inhibition of the TET enzyme shown in the nucleus in your right upper corner, and also affecting the histone demethylases. Now, the result of that is dysregulated methylation in the genome and epigenome, and this is the basis of carcinogenesis from mutations in IDH1 or IDH2 that have the metabolic epigenomic implications. If one is to look at the various genetic alterations across various biliary tract cancers as shown here, you can see that the most common alteration that's targetable is IDH1 and IDH2 mutations, predominantly found in intrahepatic cholangiocarcinoma. Some of the early studies shown here identified, in a panel of various alterations that IDH1 is an important and prevalent alteration seen in cholangiocarcinoma. You can see that this usually occurs at the 132 position in IDH1 and the 172 codon position in IDH2, and it's usually a change from R to a different amino acid. Prognostic effects of IDH1 and IDH2 have had sort of paradoxical outputs, and I'll go into this a little bit as well. So when you have cases with IDH1 or IDH2 mutant cholangiocarcinoma, you tend to see poor differentiation, clear cytoplasm and organoid arrangement of tumor cells, and scant desmoplasia. And I'll go into some other features later as well. You can see the differences noted here, particularly the poor differentiation in the IDH1 mutant compared to the IDH wild type along the lines of what I described. When you look at the prognosis, this is from patients who underwent surgery. You can see the mutation by itself was not really able to discriminate, although it looks like there's a trend. The p-value was not statistically significant in terms of outcomes. When people used a hypermethylation signature, which I'll show you in the next slide, you were able to discriminate recurrence-free survival between the hypermethylation high versus low phenotypes in IDH1 and 2 mutant cases. Despite what I've shown you here, unfortunately, it remains unclear what the prognostic implication, if any, of IDH1 and IDH2 in various settings such as surgical resection or advanced disease is. I suspect that co-mutations will come into play and help us hopefully better define subsets. When one looks at IDH1 and IDH2 mutant cases, they tend to have a little bit more predominance in the small duct histology and phenotype, and representative images are shown here in terms of cholangiocarcinomas that are small and large duct. Again, as I mentioned before, the prognostic implications have had differing results from various studies, and in this study you can see that having an IDH1 mutant phenotype had an effect on disease-free and overall survival with nice separation of the curves, mostly in the small duct type. As we described earlier with the mechanism of carcinogenesis, ultimately you get dysregulated hypermethylation of the genome and epigenome. And here you can see from the upper left panel that IDH1 and 2 mutant cases have extensive amounts of hypermethylation of the genome as assessed by a methylation assay in this study. And it goes across not just CPG islands, but various other parts of the genome as well. In some preclinical studies, it was shown that having IDH1 mutants on top of other mutations helps convert stem cells in the liver to cancers that are representative of human cancers, having cytokeratin 19 and HepPAR1 assessed as shown in the upper right-hand side panel. CK19, of course, being a very classical epithelial marker found in tumors such as cholangiocarcinoma. Again, further evaluation of IDH1 and 2 mutants done in a TCGA study shown here demonstrated that pathways linked to this are in the oxidative phosphorylation realm. So sort of connecting the dots between mutation, metabolism, cellular respiration, and epigenetic dysregulation. Some of the differences between mutant and wild type were characterized further in the TCGA study, and hypermethylation of ARID1A, which is a tumor suppressor, was one such aspect identified and found at a much higher rate in IDH1 mutants, as is shown here, with the purple dot skewing towards the right side. In terms of therapeutic intervention, small molecule inhibitors have been studied extensively now, including pivotal studies. Here I show the Clarity study utilizing ivosidenib, which is an IDH1 small molecule inhibitor, versus placebo in a second-line setting. Patients were randomized to receive either ivosidenib or placebo with crossover allowed, and I will show the impact of that as we progress. You can see that progression-free survival was only modestly improved, but statistically very significant, 2.7 versus 1.4 months. Most patients progressed at that first rescanning assessment. You can see that there's a bit of a tail in the ivosidenib curve, and that includes patients, of course, who crossed over from the placebo arm, and that's about 20% of patients who maintain long-term stability on therapy. So there likely is a biomarker that could hopefully help identify patients who are having that long-term benefit, and this will be an area of investigation. Overall survival was no different on an intent to treat analysis, only a month numerical difference and not statistically significant. Reasons for this are likely high level of crossover from placebo arm to ivosidenib arm. Using a technique called rank preserving structural failure time, one would think that it looks like there was benefit from a survival point, but the purest way to assess this would, of course, be intent to treat. On a follow-up analysis presented at ASCO GI, this trend continued between ivosidenib and placebo with longer follow-ups. I think it clearly suggests that there may have been a benefit even on the survival front, but we were just not able to establish it in the trial due to crossover. The therapy is generally well tolerated. Some gastrointestinal toxicities which are higher, cough, rare toxicities not shown here, which one should watch out for, would be QTc, interval prolongation, and neurological toxicities. Mechanisms of resistance are very much under investigation, and I would say poorly understood thus far. Some light has been shed in this arena with IDH2 mutations emerging over time in patients treated with IDH1 inhibitors as being one potential mechanism of resistance to IDH1 inhibitors. So just a quick summary of conclusions. IDH1 and 2 alterations represent the most common targetable driver event in cholangiocarcinoma. Small molecule inhibitors have completed pivotal studies and appear to exhibit promising clinical benefit. Mechanisms of resistance are yet to be defined fully, and there is some preliminary information, as I showed you. And it will be very important to identify subsets of patients who benefit from these drugs, as you saw from the cohort of patients who seem to have longer-term benefit. So if anyone has any follow-up questions beyond the presentation, don't hesitate to reach out to me. My email is listed here, and I am, again, very thankful to the organizers for inviting me to be part of this wonderful event, and look forward to the discussions that follow. Thank you.